Hello, I'm Adam Reinagel. I'm a second-year medical student here at SLU Med.
I'm Andrew Bennett. I'm a second-year master's student in speech-language pathology.
I'm Kristen McDaniel. I'm a first-year doctoral student in medical family therapy.
And I'm Michelle, and I'm in my last year of physical therapy school.
All right, so we are going to introduce you to Ms. Dorothy Johnson and what we are going to do with her to help her move back. So Ms. Dorothy Johnson is a mother, a grandmother. She is a widowed wife. She's an active member of her church at Trinity Mount Carmel Baptist Church. She's a retired secretary, and she is also an active member of her senior center. We've included.
Well, I'm going the wrong way.
We've included some pictures for you to get kind of a better sense of who Miss Dorothy is, just so that you can get to really know who she is as a person. So her family supports. She's got 3 family members that are really integral to her life. She's got her son Bruce, her son Michael, and her granddaughter Talia. So we've included a genogram. A genogram is used to show kind of overall who Ms. Dorothy is. Medical professionals might utilize this, social work, therapists. It just gives you like who she is as a person, with her family life, her health history. So as you can see, Ms. Dorothy is central to everything. She has 2 children. Bruce lives in Florida with his wife, who is physically disabled, and their 2 children. And Michael and Talia live with Miss Dorothy. Miss Dorothy's 2 parents, her mom suffered from diabetes and her father had hypertension and heart disease. This might be impacting Miss Dorothy and her health behaviors because she's inherited both of those. So she might have learned some health behaviors from her family members. And then Michael has some substance abuse history, and so we're a little concerned about that, and as well as the neglect that's occurring and some emotional conflict that might be occurring in the family.
Okay, so just to give you an overall picture, we've picked out 3 major themes or factors that are impacting Ms. Dorothy. These are by no means the only issues that we're going to look to address, but they are kind of the first or primary things that we want to work on before we can kind of make any progress in any other areas. So first, we're starting with some abuse and neglect. So we've outlined some worrisome indicators that we've noticed from her case history and from the reports upon her admission to the hospital. Just her general demeanor, her depression, her unkemptness, some signs of unexplained bruising, and her social withdrawal over the last 6 months is especially worrisome. We're also concerned about her son because there's a history of alcoholism, and there's also he's dealing with a lot of changes and a lot of stress with moving home, taking care of both his mother and his daughter, the loss of his mother after the stroke, or the mother that, or her functioning previous to the stroke, as well as his divorce. So, as Kristen kind of highlighted, we want to treat the whole system, or her whole family system, because any therapies or interventions we provide aren't going to work to their fullest if her family life isn't healthy and whole. So,
One other thing to note, if you can look at the outline that we gave you of the Prezi, you can see that the arrows are double-headed. So you identify these 3 major problems, and you should know that these are dynamic. Like, these problems aren't in isolation. These problems are dynamic. They are influencing each other. Okay, so that's just an important note. Another issue is polypharmacy. So if you look at her current list of medications, she's on a lot of medications. And what we're concerned about is we're not only concerned about drug-drug interactions, we're also concerned about drug-disease interactions because she has a lot of active diagnoses. And just the side effects of the drugs themselves. So I have mentioned here from Beer's criteria, the drugs amitriptyline, alprazolam, and oxybutynin, they are all on the Beer's criteria for potentially inappropriate drugs for geriatric patients. Ms. Dorothy would be one of those patients. And then 3 blood pressure medications I have listed. They aren't on Beer's criteria necessarily. Hydrochlorothiazide, the diuretic, is on the list, but the other 2 are not. But her blood pressure was taken 3 times during her stay in the hospital that we know at this point, and they were way too low. her target range should be like 130 over 80s, and it was like 105 over 60s, way too low. All of these things are impacting what Michelle's now going to talk about, which is fall risk. And actually, I have one more thing to talk about. One just example is she has an active diagnosis of diabetes, which is characterized physiologically by high blood sugar or hyperglycemia. That hyperglycemia can cause memory and cognitive impairment, which can then make it more difficult for her to manage her meds, which then exacerbates her high blood sugar. So you can see that there's a cyclic effect of these problems are going to make it more difficult for Miss Dorothy to get to the point where she wants to be.
So the next kind of major category that we're concerned about for Miss Dorothy's return home is her fall risk. So she has a history of falls in the past, which is also an indicator for future falls if we don't kind of intervene now. This risk kind of pertains to physical components and physiological components. So some examples of those physical components would be balance, muscle strength, and things like that, where the physiological components will include what Adam's kind of spoken about. So the uncontrolled diabetes, things like low hemoglobin, low blood pressure.
So the hospital team, along with Miss Dorothy and her family, although this was a difficult decision, they decided that it would be best for Miss Dorothy to go to a skilled nursing facility. Reason being is her primary caretaker right now is Michael, her son, right? He has problems with alcoholism, so he has agreed to go to a 25-day inpatient alcohol rehab facility to help address that issue. While he's gone, his daughter Talia is going to stay with a high school friend, a friend in her family, so all of that's going on. And Miss Dorothy is going to stay at Del Mar Gardens North. This is important because this is in her community, so this is in North County, which is where she grew up. It's also our philosophy at Del Mar Gardens that we encourage our new family members when they come in, we encourage them to create a collage along with family members maybe, so Talia maybe could come in and bring pictures, and it would be a collage of things that are important to Miss Dorothy. This is done for multiple reasons. One, Miss Dorothy can then look at the collage every day and be reminded of the things that are important to her. But also, as healthcare team members, we can walk into the room, we can see these are the things that are important to Miss Dorothy, this particular individual, and then we can ask her about her granddaughter and her son and her pet if she has one. So those are just important things. And one other thing is, if you can look at the other sheet we gave you, the handout, this is actually printed off from the Del Mar Gardens North website. For the services and amenities, I've asterisked the things that are the most important for Miss Dorothy's care. So you can see on there that we have dental, optometric, and podiatric care. All of these are going to prove useful potentially for Miss Dorothy. Unlimited visiting hours are really, really important with her social history, her emotional history, medical history. And full rehabilitative programs, including speech, physical therapy, occupational therapy. And then these daily social and recreational programs, including cooking classes. So they have cooking classes with a dietitian where they can teach how to cook healthy meals and other things.
Okay, so the central thrust of our care team were the goals that she communicated to us, which was to return home as soon as possible without being burdensome to her family, as well as re-engaging with her preferred activities at church and at the senior center. So anything that we do or anything that we address is with this in mind. And then we can introduce you to our team. We have a nurse who looks a lot like our primary care physician, our physical therapist, our occupational therapist, our medical family therapist, our dietitian, our pharmacist, our lumberjack speech pathologist, our Raggedy Ann social worker, our geriatrician who's giving a thumbs up to old people in Hawaiian shirts, and as well as her pastor, who will be kind of a liaison with the ministries at her church. And some of those ministries that we'll be collaborating with are transportation to get her to and from church, from the skilled nursing facility or from home, health resources, meals, as well as music, and some financial guidance and support.
One other thing we're going to do is, you saw that there is dental care, there's optometric care that comes in, so not necessarily referring out, but having them come into Del Mar Gardens North. Because she does have dental problems, those really need to be addressed, and you'll learn more about that when our speech pathologist, our lumberjack speech pathologist, talks about aspiration risk and things. Also, the ophthalmologist is really important. She has a history of macular degeneration, or an active diagnosis of that. It's really important that we address that with the ophthalmologist, especially with transportation and driving. That's why she's concerned.
So, Ms. Dorothy and her care team realized that the abuse and neglect is a serious concern. While we are all required as professionals to report this to the state, we decided as a team that I would be the one that would report, obtain a case number, and give that to everybody so that they can make notes of that in their case files. As well as doing family therapy to kind of address these patterns of behavior, the alcoholism, and basically just how the family can work together to keep Ms. Dorothy safe and healthy.
So managing medications is another really important part of Ms. Dorothy's care. So the 3 team members that are the most essential in this managing of medications are the geriatrician, the nurse, and the pharmacist, and they will work together and have conversations about how to approach this situation. So the technique that we're going to use as a team is a technique called ARMOR, and ARMOR stands for Assess, Review, Minimize, Optimize, and Reassess. This is a tool that's used, I think it can be used across the board in medical healthcare professions for looking at patients, especially geriatric patients, lists of meds. So, first thing we'll do is assess. So we've already kind of mentioned this. We've looked at EARS criteria, we've assessed which drugs are problematic. We then review. So I'm going to give you just an example. I could go on for 20 minutes about the interactions that are going on, but just one example of a drug-drug interaction is that oxybutynin, which is the drug she's taking, that Ms. Dorothy is taking for her urinary incontinence and urge, it may increase her serum concentrations of HCTZ, which is her diuretic. So you have to think about those interactions, like that will actually affect serum concentrations of that diuretic and could cause potential problems. Drug-disease interactions, we have amitriptyline, which is her antidepressant that she's currently taking. That may alter her glucose regulation. So as we talked about earlier, it's super important that her diabetes gets under control, which we'll talk about later. And then the adverse drug events, alprazolam, which is the drug she's taking for anxiety, it's the anti-anxiety med, can cause impaired cognition and delirium. So that's a huge problem for a patient, for Ms. Dorothy, because she needs to be able to be as cognitively aware as possible. We want to minimize, so we want to eliminate oxybutynin. We want to eliminate amitriptyline after gradual dose reduction. You don't want to just take someone off of amitriptyline or they'll have withdrawal symptoms, so you'll gradually reduce the dose. And then an alternative to amitriptyline would be bupropion. It's an alternative therapy that was highlighted in a start and stop tool that I was using that nurses typically use. And then atenolol, which is the beta blocker. She's on 3 blood pressure meds. I already said she got her blood pressure taken 3 times, way too low. Take her off of one of those medications. Atenolol can slow her heart rate. That can cause problems. So that's the first drug that we as a team would decide to take Ms. Dorothy off of. And then finally, you want to reassess. So when you're doing all of these things, you're taking Ms. Dorothy off of medications, changing things, gradual dose reduction. You want to monitor her heart rate. You want to monitor her blood pressure. You want to monitor any other necessary vitals or essential vitals. And then reassess her cognitive status and mood during her stay at the skilled nursing facility by re-giving the SLU cognitive assessment and the geriatric depression scale as she's there to see how she's progressing and if the drugs are in fact the things that are causing these problems.
So the next thing that we're going to address as a team is fall risk. So PT and OT, you can click on the next thing here. So PT and OT are kind of going to work on overall mobility to do this. So safety will be a big thing, improve her ambulation, her balance, and her overall fatigue with exercise and activity.
The geriatrician, she does have an active diagnosis of osteoporosis as well. That's a problem. It increases her fall risk. She had her DEXA done 2 years ago. It needs to be repeated based on guidelines. We also want to add vitamin D to her regimen. I know it's not always good to add more. We're trying to minimize. But in this case, vitamin D is really important for bone health. Her vitamin D levels were taken twice during her stay, and they were both really low. Home health nurse is going to assess home environment, so the home health nurse is going to go to Ms. Dorothy's home, assess the home for any kind of risks for falls, and will educate Ms. Dorothy about safety at home, along with her family. This is important. It's not just Ms. Dorothy, but her family needs to be educated as well.
Right. So as the MedFT will engage church members because they've agreed to be part of this care team and go to her home and interact with her. They need to be aware of safety risks and how to best keep her safe.
The next area we're going to address is Ms. Dorothy's ability to perform ADLs and IADLs. These are kind of an essential component for her to be able to return home safe. So like we talked about, physical therapy and occupational therapy with nursing, we'll kind of look at the home environment and assess that. We'll also do things like energy conservation, and again with the safety and mobility.
Okay. Great. Okay. So another area that we really want to address is her social interaction and engagement, as well as her depression. So those are the team members. And then, so that involves like assessing, as a speech pathologist, I would assess her cognition and language abilities, figure out how she was pre-stroke, and where we can go from here. Educating the family on how best to interact and communicate with her, working on some voice therapy to address her communication as well. And some social cognitive communication intervention.
As MedFT, we would engage the family and family therapy, like I previously said, because her family is really important to her. Figuring out what's going on in the system about the abuse and alcoholism and working those things out so that she can still engage with her family, as well as getting her connected with her church members and making sure that that process is going smoothly and she feels comfortable talking to them again.
So this is also where PT and OT will really work to get her back to going out in the community and having tolerance and the skills to participate there and be comfortable.
So as we said before, controlling diabetes is really, really important. This diabetes is causing a lot of issues. So the nurse, diabetic wound care, the nurse will provide diabetic wound care. Also educate Miss Dorothy on the importance of foot care as well. So that's a really, really important role of the nurse. The geriatrician will ensure that the current meds are sufficient to control the hypoglycemia. It's kind of hard to say right now. Is she taking the medications? Is she taking the metformin and the glucoside? Or is she not? So if she can take those medications during her stay, we can then see if that's the problem, and we want to make sure that they stay under control. You also want to address kidney disease. Kidney disease can be really, really problematic, especially if it leads to end-stage renal disease, so then she has to have dialysis. Well, dialysis is really, really going to be a burden on like reaching those goals that we talked about earlier, getting her home, getting her more active in her community, church community.
So physical therapy and occupational therapy will help with diabetes control. To kind of come up with an exercise program, there's studies that show that people with diabetes on exercise programs in long term have decreased risk of heart problems, vascular problems, and then it also has an effect on controlling insulin and helping regulate.
So the MedFT will have her show an example of taking her medication. Just to identify, does she know her meds? Does she know when she's supposed to take them, what meds they are? And also for health behaviors, she might be confused about meds. She might have learned behaviors that won't help.
And then lastly, we want to reduce her aspiration rate. She presents with a moderate oral pharyngeal dysphagia. So speech pathology and dietetics will work on any dietary accommodations. And this will also contribute to controlling her diabetes, to find like a diet that works for her, that can maintain her nutrition, but also won't exacerbate any issues with her diabetes. As well as doing some swallow exercises, educating her family and caregivers, and counseling to reduce that risk. Also working with dentistry to work on oral hygiene, maybe getting her fitted for some dentures to improve nutrition, and again, reduce any risk of admittance to a hospital for an avoidable pneumonia.
And then lastly, OT can work on positioning, so she's in a good position when she eats, a comfortable position, and then also energy conservation with utensils and with all that kind of goes into eating.
Before we go to the last slide, I just want to mention, hopefully you're seeing that these goals are interconnected. So as you can see on your sheet, they're double arrow. There are double arrows. Some of them are harder to see than others, but they interact. These main goals interact. And there you can see the team members are working together to achieve these goals along with Ms. Dorothy. So that's a really, really important part. Okay.
Great. So this whole web of our team and our goals will eventually lead us to, after we've kind of assessed Ms. Dorothy and spoken with her and counseled her, and she feels comfortable to go back home, and we also feel that she can comfortably move home independently. It'll lead her back home into her community, ideally where her son and granddaughter are there to welcome her and are prepared and educated on how to take care of her and maximize her quality of life. So, yeah, that's it. That's just trying to think of a way
Bless you.
to transition.
Questions?
So, I'd like to hear from each of you in terms of what you feel personally you got out of this experience.
Sure. Okay, so I personally, I didn't really even know, and I think a lot of us on the team, what medical family therapy was. And so we definitely learned the benefits of having a medical family therapist on the team in terms of it totally makes sense to include the family because that's ultimately what the patient is going to go home to in our situation. And she wants them to be involved. So having someone to kind of counsel that and stay with the case kind of as it moves is kind of something really neat.
I think I learned how little I know about all the other fields represented here. I think, and the different priorities we have, or the different lens we bring to it, because going in I was like, oh my gosh, like she has had a stroke, she might have cognitive or language impairment, like she's got this depression or this social withdrawal, like we got to get her back to church or get her back to the activities that she does, like that's the only way she's going to improve. And then coming together with him, it's like, well, like she's got to be able to be mobile and to be able to get around. Or any therapy that I might provide, like she's not going to be able to use those skills if she can't get to those places. Or if the medication that's interacting with her is reducing her cognitive abilities or kind of hindering her. So learning about that from was really impactful. I'm like, okay, like as hard as I might want to try, like there are other factors that need to be aware of or that we need to work on as an entire team before like my pie in the sky goals of like getting her to a certain level can really be achieved.
Yeah, so for me, I think what I learned the most was that these other fields really are like collaborative and they do want to engage with the rest of the system. I guess in my mind, I'm like, I've got to fight everybody and we've got to make them collaborative, but they're actually that way already. They just might not know how to go about that or do it differently. I think particularly something I learned interesting was with speech pathology was that I had no idea that they had concerns about engaging community members and bringing everybody in. That was very like shocking and also like exciting because I thought honestly that we were kind of alone. Yeah, we're not alone. People care about that too, so it's exciting.
I guess for me, I go to one moment during one of our team meetings where Kristen introduced the idea of a genogram, which I had never heard of. I've heard of a pedigree in genetics, but I've never heard of a genogram. And what she did was so cool. She went up to the board and she mapped out a genogram, and she explained every little piece to all of us. And then after that, Andrew and Michelle mentioned ICF, the ICF model, because we were trying to figure out how do we frame our goals. And so they mentioned the ICF model, and then they went on to sit down and educate us on the ICF model. They pulled it up, they talked through it. So it was that was a really cool moment.
I have to have ideas for Halloween costumes.
Jerry in a Hawaiian shirt, like the costume of the year or something.
Yeah, I need to borrow the stethoscope from you guys for this weekend.
It worked out well. It was around Halloween.
So, great job. For your team meetings, are you planning to always meet physically with this patient, or
Yes.
what's the plan for that?
So one of the things that this facility would do is meet weekly with Ms. Dorothy, her pastor, her family members, as well as the team that's actually there to discuss the goals, where she's at, where they need to go forward to reach those goals.
Another important thing to note there, Kristen was awesome because she brought up, we were in the middle of our conversation at one point in time listing out the problems, and there's a lot of medical jargon in the problems. And she commented and said, well, if Miss Dorothy's part of this team, like if she's part of these team meetings, she's not going to understand a lot of what's going on. And so I love that she brought that up because we weren't in that. I don't think any of us were really thinking that direction. But it was really, really important for us to be aware of the language that we're using in those team meetings, especially if Miss Dorothy's there.
So you guys laid out this beautiful plan for Miss Dorothy. As you were going through it and you were kind of assigning your roles for everybody, did you identify any areas where there may be a challenge for collaboration and how they can overcome that? Or because the plan is beautiful
Yeah.
And if, in the real world, it'd be great if that's how it worked, but sometimes we do hit challenges with team members wanting to go one direction while others feel like another direction is more important. So just wondering if you guys, even amongst yourselves, found it was challenging to prioritize.
One of the first things we kind of talked about, not necessarily amongst team members, was if Miss Dorothy didn't want to go to a skilled nursing facility, because that is a common concern. Patients want to return home. So we definitely had a conversation. Initially, it's kind of like a segment off of your question, but initially, since she is a member of the team, kind of deciding how we were going to go about that, and feeling like this really was the best route, where she'd get 5 days of therapy and she'd have everybody right there and nobody had to
Removes
make
a lot
sure
of the
she was
logistic
safe
problems
at
of
the
trying to
home.
collaborate if, you know, so many people are on
But we
site.
had to come up with like kind of a second option if that wasn't going to be in the cards for her. So I don't know if we have any.
I don't know if we had any huge issues with like kind of prioritizing like the goals or whatnot. I mean, we all work pretty well together. I mean, if we add the other 8 or 9 people we had on our team, we might have struggled a little bit. But
We were trying to think about the ICF. We were trying, when we initially described the goals, we were trying to implement the ICF model. But what we realized was she has so many so many diagnoses that that seemed like it was more of something that you would look at a patient that comes in with a problem, and then you would look at all of these factors. Whereas she has so many problems that we found it difficult. That was a challenge, I think. Like trying to think about how would
And
you
we found a
apply
need
that.
for everybody was kind of the easy part, I
Yeah.
guess, that everybody was really needed.
or
Yeah.
like we would sometimes get discouraged and be like, oh my gosh. And I just thought it was like, okay, well, like it's like you fall out of a boat, you're gonna hit water. Like if we're all contributing at least something to her improvement, like we're moving forward. And I think looking at things holistically, but also choosing sort of like thematic factors that are all interconnected, it made it easier for like each member of the team to kind of see where their treatment was in relation to everything else, as opposed to kind of compartmentalizing it and just thinking about it's like, okay, well, I'm the dietitian and I got to make sure that, well, you know, X, Y, and Z is right, or I'm the speech pathologist and I got to make sure that I'm doing this, this, and this. It was helpful to, I think, organize it in our minds that way, and to look at it like that, to just so you always have kind of in your peripheral vision where everybody else is working.
Yeah, the collaborative part you nailed. I mean, as far as the team approach, and I think that kind of the cycle of things interacting was great. Do you see any challenges if there's maybe too many professionals on the team? Because you had a lot of roles and things like that. Do you ever see in a collaborative team where that may backfire in a situation? Maybe not necessarily this, but maybe just in general.
There was an issue here when it came to the medical side, like the medicine side, because in some situations you have all of the specialists involved, right? So you have a cardiologist, you have a pulmonologist, you have an endocrinologist, you have all of these specialists, and then you have a primary care doctor. But Miss Dorothy, say Miss Dorothy goes to her endocrinologist, well, he or she is going to prescribe something to treat the endocrinology problem. And so then you run into this problem. So then what I decided from the medical standpoint at least was a geriatrician would be the member of the team. And if the geriatrician needs advice or needs to seek counsel, she or he will call the specialist and ask for counsel, rather than include all of the specialists on the team. Like that's just one example.
When we talked, we also kind of talked about how there's not exactly an ideal way to communicate, like, necessarily what you did that day. Like, I know in the hospital you have to go into everybody's note and you have to click and you have to read, you have to click and you have to read, and if there's 8 notes in there and you're clicking and reading, do you even have time to click and read all the notes? So we were kind of thinking like it would be a good idea in theory to have something where you could either like just write like the most important thing from your day, or like change in blood pressure, change in whatever, like somewhere that was easy that everybody was looking at, but we didn't quite come up with an easy way with how kind of it realistically is set up today.
That would be $1 million idea.
I jokingly suggested like, oh, well, we can have like a team group me, like our group project, like a group messaging system, but that was more jokingly. And I think we thought of that, like considering like when we're having team meetings with Miss Dorothy, do we want the 12 other professionals in the room with her? Because that is an extremely, especially if we want her to engage with us honestly about what she wants or what she can do, like that's extremely intimidating and overwhelming to have 11 people all giving their point of view. So
We have